Thank you, Shreya. Thank you, everyone, once again for joining us for another session today evening. So we are starting to hear about the management of symptoms. So today we'll start with gastrointestinal symptoms part one, where we'll be able to learn about or refresh about the management of nausea and vomiting and constipation if time permits. So today we have as a faculty Dr. Krithika. Hi, Krithika. So
Hi, Dr.
Krithika,
Sridevi.
hi.
So nice to see you after a
Yeah,
very
yeah,
long.
exactly. So Kritika has done her MD in palliative medicine from Tata Memorial Hospital, Mumbai, and she's currently working as assistant professor in Department of Palliative Medicine and Supportive Care at KMC Manipal. And we have worked together for a brief period of time over there in Manipal. And I think after that, we are seeing this for the first time.
Yeah.
So welcome, Dr. Kritika, for this session. We have more participants will be joining, but we'll start the session. We have around 70 plus participants for this program from different parts of India, different specialities. So
Okay.
welcome you for this session.
Thank you so much for the grand introduction and welcome here. And I'm so nice to see all of you. I have had prior sessions and it's nice to be in touch. There are so many physicians who are interested in doing this fellowship and being part of this course. So, moving on, as we have discussed about today's presentation, please excuse me. My voice is very bad today. Then it may be possible that in between I may not be clear. Is my screen visible?
Yes, yes, it is.
So, as we've had an introduction about like looking at GI symptoms mainly, I'll be touching upon two important topics: nausea, vomiting, and constipation, where we come across it routinely in practice, but often at times it's challenged to assess appropriately and manage. So the main topic over nausea and vomiting will be I'll just mainly give you an understand over patterns that we see, how we approach to a patient, and the appropriate choice of the antiemetics. Basic definitions in the start. What is nausea? It's mainly like an unpleasant feeling or the need to vomit. It is often accompanied by deep salivation, cold sweating suddenly there would be a pallor or feelings of tachycardia would come in. The vomiting is mainly a physical process of the forceful expulsion of contents, whereas you'll find somebody with even retching where it's mainly preceded with nausea along with just rhythmic labored spasm of the muscles of the diaphragm and the abdomen, and may not eventually lead to vomiting at times, may just be only to this much. So when we know about what is nausea vomiting, let's also find out why it is important in our practice. So it is seen in approximately 36% of patients in the first contact with our service, and we find it increasing progressively as death nears. So it is mainly around 62%, 1 to 2 months before death, and 71% of patients will experience it in the final week of life. So why do we term it as, it should be, because it should be assessed as together as a unison. Not only will be nausea present, nausea, vomiting, along with a cluster of symptoms like fatigue, decreased appetite, breathlessness, drowsiness could be accompanying it. And when you rate it in terms of how the impact of nausea and vomiting is on a person's general activity, emotional well-being, it is majority of the times rated more than 5 out of 10. So it can affect in various ways, where it affects the patient's daily functioning, quality of life. It may also lead to non-compliance of treatment sometimes, because you might prescribe certain medications, they might have a preceding nausea with it, not addressed well, they might continue to just stop all medicines, and they'll say no effect, I started having nausea and I just stopped everything. Or refusal of effective pain medications because of the known side effect of nausea along with it. Sometimes even there could be family distress, other beliefs, and the patient and the family hold within terms. There could be many underlying issues that could be triggering it, or own patient's perception of the causative factor. Maybe just a simple thing that you might give, not a painkiller, but you might just give in some medicine to say sleep, and they might be like, this causes nausea to me, I'm not going to take it. give me some other medicine, this is not effective. It may not be even to do with any particular medication. You might have advised some particular different treatment ongoing, and they'll be like, this injection, maybe just a paracetamol, and be like, this injection caused nausea. They might attribute it because it might have coincidentally happened at that time, but they might remember it and share it that way and say, this is what it is. So when we look at further on assessment, these things also need to be kept in mind while talking to them. Prevalence around in advanced cancer is ranging from 6 to 68%. In AIDS, heart disease, and renal disease, it is persistent around to up to maximum 50% of patients will have it. Mainly in advanced cancer, you'll find it will be a combined nausea vomiting present in 62%, and isolated will be in only 34, along with vomiting in 4% of patients. So comes to the part of assessment. Before that, a general idea. We have learned this way back in our medical school, and we have come across this chart quite often when we are practicing. And we tend to sometimes, overlook because we are very in depth into we know certain antiemetics, and then we might try to give in a combination of antiemetics based on what a simple assessment would be. But when we are trying to really treat nausea and vomiting, having an awareness about various pathways by which nausea and vomiting is triggered can help a longer way when we are trying to, bring down the symptom burden and appropriately manage it. So mainly three pathways that work by is the central pathway, the vagal pathway, and the vestibular pathway. In each of these, there are various control centers involved. In the central pathway, mainly through the brainstem emetic control center, that is, you'll have one of which is the chemoreceptor trigger zone, the dorsal motor nucleus of vagus, nucleus tractus solitari. This forms a complex in the area. Whereas through the vagal pathway, it is more from peripheral stimulation, that is from the GI tract, from higher centers by triggered due to smell or vision of certain nauseating things, or through the pharynx, or through the vestibular cochlear nerve around the vestibular pathway. So the main physiological process that happens is there is an extrinsic neural control where the vagal, which is the parasympathetic system and sympathetic system, is involved. It could be an enteric brain activity or excitability of smooth muscle cells controlled by transmitters. So when we understand this physiology part, the MSS pathway, which is present when mainly the receptors, the neurochemical receptors, which are involved in triggering nausea and or vomiting based upon from where the afferent signal is coming in through. So each area has its own different set of neurotransmitters through which it is mediated. It is important for us to identify different neurotransmitters at different sites so that when we are trying to assess, manage, you might want to have medications which are directed at these neurotransmitters rather than a generalized approach. That way, we will have a better control over the symptom because you're giving a very targeted treatment and not a generalized treatment. Major common neurotransmitters that you'll find as receptors which are there is 5-HT3, NK1, dopamine receptors, alpha, then you have acetylcholine and the mu opioid receptors. Mainly through these receptor points is where it is mediated along. Now along the MSS pathway, the area postrema is where it is acting mainly through the 5-HT3, 5-HT2, dopamine, histamine, NK1, cannabinoids, acetylcholine muscarinic receptors. Mainly in the emitting pattern generator, that is the vomiting center, the acetylcholine, H1, that is histamine receptors, mu opioid receptors, 5-HT2 and NK1 are commonly present in through which nausea or vomiting is mediated. So below graph is just a process of how nausea triggering vomiting would occur. This is mainly the physiological and physical process that happens leading to vomiting. So when we approach a patient with nausea, the main rule of thumb would always be first identifying the etiology, treating any correctable causes or complications or a consequence because of which nausea vomiting is triggered, and providing targeted therapy based upon the receptor involvement. When you want to take a particular history and you want to examine The process would evolve around taking a thorough history in terms of these factors, where you might want to know the kind of quality of nausea that the patient has, duration that it has been from, how, whether there's any diurnal variation, intensity, how much it is, whether the associated vomiting and post vomiting there is any relief of symptoms, whether there's any pain associated with it, altered bowel habits. There are certain aggravating factors like sight or smell of certain food substances, which could trigger nausea or even trigger vomiting. Does it worsen after eating? How long after eating does it worsen? Does it come in immediately? Do they vomit after like 4 or 5 hours, or many hours have passed by and in the night they are vomiting up in a large amount? How is their activity throughout their day? Are they moving around? They're mainly bed bound. What happens? Or sometimes even your movement is whether any movements suddenly trigger the episode of nausea there within. Important part would be in our practice in palliative care is there's a lot of polypharmacy, especially in the elderly group population with multiple comorbidities. They'll be on a entire, a big chunk of drugs that they'll be going on together, and that would lead to interaction, drug interaction, side effects of certain drugs causing nausea, vomiting as a symptom. So a imperative drug history, thoroughly identifying what all medications they are going, what all they are taking through, going through each one of them, is important when you're trying to also address this symptom. Also, along with that is when we see in oncology, a lot of patients will have cancer treatment related, radiation induced nausea, vomiting, or chemotherapy induced. I'll come ahead in the lecture where we discuss upon those two topics. When we go towards physical examination, it's mainly about looking at any abdominal pathology to rule out any organomegaly, masses, look at bowel sounds, whether it could be a bowel obstruction leading to it, or and also rectal examination, because in certain patients with impacted feces, severe constipation, almost obstipation being developed, and they are not able to tolerate food orally and they end up vomiting. Also look for any causes where there could be rectal impaction with stools. Other certain signs may could be in terms of patient in infection, in any metabolic abnormalities like in hyponatremia, hyperkalemia, hypocalcemia. You'll have patients coming with symptoms of nausea and along with vomiting, severe renal dysfunction, liver failure. They would have a persistent nausea as a symptom, or in certain neurological issues. Now, when we want to really do any investigation per se for the symptom, it is not there, but to rule out causes for which the symptom is there would be based upon your physical examination and any findings that would accordingly lead you to take any further decisions for making any radiological investigations or any biochemical blood investigations that to rule out metabolic abnormalities, sepsis, infection, all of these causes could be assessed. So when we come to this topic, important ones on choosing an antiemetic, um, this further few slides you'll be seeing through a general rule as to what could be the likely etiological reason for which nausea vomiting is there, and what preferred class of drugs you could use when you want to choose an antiemetic. I'm sure there's a huge table with us. We have learned in pharmacy, and I may not be able to cover every drug here and explain in doubts. But yes, as a handy reference guide for you, if you have a basic idea of what would be the etiology and what kind of drugs you could use, it will help you to make the appropriate choices. Now, when I have divided this based upon the clinical syndrome, so in cortical areas, mainly things triggering would be metastasis, or there could be meningeal irritation or mentation. Metastasis likely due to any cerebral or due to liver failure causing toxin buildup, affecting cerebral function. Accordingly, based upon that, you might have to either look at treating the reversible causes. Say, suppose if it is raised ICT, it is direct stimulation of receptors in the vomiting center because of certain brain lesions, or patient is undergoing whole brain radiotherapy, triggering nausea, vomiting. So therein you might have to consider putting in on medications either to reverse the particular causes which is causing in, or add mainly around which works around 5-HT or histamine or dopamine receptors. So medications which are targeting these receptors, you could add in those and control nausea vomiting. Whereas with mentation, in certain patients with severe anxiety around their illness, in terms pertaining to psychological distress, which could lead to the disease advancing, or a prior perception that such symptom burden is a sign that maybe disease has recurred, where there is collusion with the patient and they don't have full information. Anxiety could be an underlying mechanism by which nausea is triggering. Their use of anxiolytics, especially benzodiazepines, low dose benzodiazepines acting over a longer period of time, like throughout the night, can help you reduce those episodes of anxiety, which can lead to, which can trigger nausea. Vestibular, we are aware that movement either caused due to medication or motion sickness. So it is a vestibular stimulation and it causes stimulation of the acetylcholine or histamine receptors. So you would use, if it's a medication induced, you stop the offending drug. If not, it is because of stimulation of acetylcholine or histamine, use accordingly antihistamines or anti-acetylcholine receptor drugs. Chemical, now chemical has a varied different ways. One of them would be medications, in that which would be either the opioids, which you'll commonly find amongst patients being looked after under palliative care services, then chemotherapy or radiotherapy induced, or medications used other than for other comorbidities, like in heart failure, you'll be using digoxin. Patients with infection in neutropenic sepsis coming up, or who are under your care, requires maybe developing some pneumonia, GI infections, you're on antibiotics, and that antibiotics could trigger it. Certain anticonvulsants or toxins in food poisoning. So depending upon this, your choice of antiemetic might differ. Especially in opioid-induced nausea vomiting, it is mainly due to the activation of the chemoreceptor trigger zone or delayed gastric emptying. So something which may be a dopamine receptor or histamine receptor antagonist, or along with that, a prokinetic agent like metoclopramide, cisapride, that can also help in averting this nausea due to opioid that's being used for this patient for appropriate symptom pain control. So you might have to balance at that point of time how severe is the nausea triggered due to opioids, whether you might need to change that offending drug also. Sometimes you need to rotate an opioid. Say patient has severe intolerance to tapentadol, tramadol, or morphine. You might have to rotate to fentanyl for some period of time so that you can let that symptom effect reduce and then probably see back again to go back to morphine if it is feasible to give. Chemotherapy, radiotherapy is mainly through the 5-HT3, NK1, CTZ receptors. Accordingly, you will choose basis on this the appropriate antiemetic. The another topic is where we're looking at impaired gastric emptying and visceral causes would be either due to mucosal irritation, mechanical obstruction, or motility issues. Now, mucosal irritation is quite common when you see patients who are on active chemotherapy or radiation-induced colitis, when radiation is being given to the abdominal area or for spinal metastasis. They might come with severe nausea post initiating radiation therapy. Therein, also it could be due to NSAIDs use that is ongoing. Some of these patients might be on aspirin. You might even add in at times due to bone pain, you might add some COX-2 inhibitors, and that would also lead to aggravated gastritis. There, you might benefit by using cytoprotective agents like more like a syrup formulation causing a film layer over the gastric ulcers, duodenal ulcers. So you have various formulations of antacids, you have sucralfate, which can be used, and that can bring down the triggering of the symptom to a larger extent. Mechanical obstruction, as we know, it could be either extraluminal, intraluminal, based upon the causes. Mainly, if it is constipation induced, manage that. Suppose it is bowel obstruction induced, it's a single level of bowel obstruction, possibly reversible. You might go for surgery for a diversion colostomy, and then that way avert the a particular symptom and the complication arise. If it's irreversible, like there will be multiple levels of obstruction, you're not able to do a surgery for this patient, you might manage it by appropriate bowel obstruction management, manage the fluids intake. Steroids are used to reduce the gut wall edema. Antisecretory agents are used so that you reduce the gut output. the volume, the water output that would be there, bring down that, and eventually affect in probably it also helps the anti-secretory agent like we use is octreotide, can also help in reducing bowel spasms and thereby reducing the symptom of nausea and vomiting. Another of topics about motility, we saw various reasons where it could be due to opioids or other medications. Ileus that can happen in patients who are especially post-op, you'll find, or hypokalemic paralytic ileus you'll find in. Gastroparesis, which is common in patients who are on morphine. Certain procedures might cause GI immobility, or there could be gynecological procedures that could lead to it. So mainly it is seeing the underlying cause and identifying mainly the receptors that are involved in it and treating it with an appropriate antiemetic choice. I'm sure this presentation will be shared with all of you, so you can go back and look at this chart and have at least a broader idea about each symptom and possible etiological cause for which you can appropriately choose an antiemetic. I talked about this earlier about chemotherapy induced nausea vomiting. Now it is the major neurotransmitters involved is substance P, serotonin, and dopamine acting on NK1, 5-HT3, and D2 receptors. Now, it doesn't mean that every chemotherapeutic drug will cause nausea and vomiting. There are classification in terms of very highly emetogenic to minimally emetogenic. Many of the patients in adult population, we would see that they would be in a lot of these platins drug, taxanes and all, which are known to cause highly emetogenic profile where they will known to cause severe nausea and vomiting. So if you see this chart on the side, which mentions cisplatin cyclophosphamide is one of the highly emetogenic where more than 90% of patients will have it. So on and so forth to vincristine and immunotherapy drugs, that is all the MABs will have minimal nausea vomiting as one of the side effects. When you are trying to treat mainly chemotherapy, nausea, vomiting, you also need to look chemotherapy induced nausea, vomiting, but seeing the type when it presents in. There is NCCN guidelines, ASCO guidelines, which tell about managing CINV, where it is divided into types where it will be acute, delayed, breakthrough, refractory, or anticipatory. Most of the protocols right now, chemotherapy protocols, have this drugs already given anticipatory. So the ones that are occurring immediately or delayed are quite likely taken care of. But in certain patients, due to repeated cycles of chemotherapy, they might have refractory nausea and vomiting. Recent evidence suggests giving olanzapine, which is a centrally acting cortical level acting like it's an antipsychotic, but in patients with CINV, it has shown to provide a good antiemetic effect. So there is a ASCO guideline as well as NCCN says that we can start at 10 milligram in the night, but more often in Indian population, we've seen 10 milligram will make them very drowsy. So we tend to go slow, start smaller doses, say around 2.5 milligram HS, and then build up as and when required. And we have seen very rarely patients have gone beyond using 5 milligram HS dosing of olanzapine. Certain times we do consider in anticipatory nausea vomiting, which is mainly due to a conditioned response prior to chemotherapy. You'll find is that the sight of a IV bottle next to them only might trigger it. So that itself is what we call as anticipatory nausea vomiting, and there olanzapine, lorazepam, or haloperidol centrally actings have helped better. And so starting at very smaller doses and then titrating up would be the rule of thumb here. Similarly, in radiation-induced nausea vomiting, like how chemotherapy you have highly emetogenic risk levels. Similarly, here, depending upon the area of the body that is irradiated, that determines how emetogenic would that would it be. If it is entire body irradiation, maximum more than 90% of patients will have the symptoms. Whereas if you go lower, if you are away from the thorax and the abdomen, more towards the extremities, craniospinal, cranium, head and neck, there the chances of developing nausea vomiting are lesser. As we had seen that anticipatory prescriptions are given patients who are on CINV. Similarly, in radiation-induced nausea vomiting, also depending upon the risk profile, there is antiemetic guidelines being put in. In majority of these patients, 5-HT3 receptor antagonists plus minus dexamethasone help in a longer way to bring down the symptom burden. So ondansetron being used, palanosatron is being used in patients. Now, when you consider between ondansetron, palanosatron, ondansetron also has a tendency to cause constipation. Dosing is required every 6 to 8 hourly. Whereas in palanosatron, although the cost is on the higher side, but you need a once a day dosing, and patients had a very good control. So in our practice, some patients who can afford, we routinely prescribe palanosatron, and it helps them in a better way to control this nausea vomiting symptom due to radiation. While we talk about pharmacological, there are also inclusion of non-pharmacological measures that can help in trying to let the patient cope up with this symptom in a better way. So as I talked about in history taking, it's important to uncover a lot of hidden concerns, unasked questions that could be there, anxiety around certain things, drugs, they might have their own preconceived notions about certain medications or certain procedures that is being done. You have to educate the family patients about what is happening, likely to happen with the patient's body, and avoiding these anxiety and concerns will help in a longer way. Fear and family's hope is important when we are trying to also assess for history. It has been shown in certain studies that certain household kitchen items which have a strong sense of smell, especially like ginger root, lemon peels. So what we tell families or patients is you can have a piece of ginger kept in the mouth or just smell it. Even the lemon peel, they could just nib on the entire lemon, just press it a little bit so that sudden fragrance that releases off due to the lemon oils can help in relieving of that nausea and vomiting. They could even try this while they are undergoing chemotherapy radiation, that before they eat meals, they try to take this particular smell so that whatever obnoxious smell that they are probably perceiving goes off and they feel a little bit better. Other measures that, along with what you're doing for increasing gastric emptying and decreasing the gastric distension, would be to advise them to have a liquid to a soft diet, frequent small meals instead of larger meals. Whereas sometimes you might see patients with um, uh, gastric outlet obstruction, there's impending gastric outlet obstruction. They might tend to have larger quantity of meals and then be have early satiety. They might tend to feel bloated, or then they just vomit up everything out. Therein, if you tell them have frequent small meals, more soft, uh, sorry, liquid meals, they'll be able to tolerate it better. And food should be low in lipids and fiber in these places because that can act more as a probiotic, lead to also fiber in patients who are having opioids. It might lead to more amount of fecal impaction in these patients. So we always tend to have this thing that, if it's constipation, if it is nausea and it's this, have more fiber, have more of these things, eat all of that. But you have to be very careful in patients who are on opioids. Fiber in high fiber diet can lead to fecal impaction in these patients. And measures to avoid other noxious or associated stimuli would be that a lot of times we might find in our families that who are living in a low socioeconomic strata, or as a huge joint family staying together, there may not be enough of privacy for this patient. Patient may not be in a separate room away from the main kitchen area or from away from certain places outside of outside of the house, in the environment around. My experience I have seen where I was in TMH, we used to do home care in entire area of Mumbai, and I've had home care even go to smaller slums or smaller household areas where it was a very cramped up environment. Kitchen is right next to where the patient is sitting. Especially in Indian cooking, we have the tadka that would lead to triggering sudden nausea and vomiting in patients. Maybe at that point of time, ask simple changes when you're cooking. Have the patient sit outside on a chair outside of the house or away, if possible. Maybe like a room divider put in so that the smell doesn't come out through. Simple things like that would also go a longer way. Even when they are being present, when they are given meals, when they are provided with their meal times, avoid any particular food with certain strong odors. When we cook in our Indian households, there's a lot of use of spices. Different foodstuffs, when cooked in a particular way, might lend a strong odor. So to avoid that, we have to try and ways how we can mimic the when we can, mask the odor of it, mask the sight of it, and give foods like that. And presenting it in a more pleasant appearance might might relieve the trigger of nausea or vomiting. So when I talk about all of these things, mainly the rule to remember is correcting the correctables. So finding out what are the common drugs that their patients are using. If it's mainly in our practice, we see it as drug induced, who are on off treatment, off the disease modifying treatment, and only on supportive care. Constipation, gastritis, raised intracranial pressure with most of the patients with brain mets. A lot of our patients have reduced immunity and they tend to develop oropharyngeal or esophageal candidiasis, which could also trigger nausea. So it's important that every time you assess this patient, have a look at the oral cavity, because many of them might be on steroids while taking radiation, or they are post chemotherapy on steroids for nausea vomiting. So then they tend to have candidiasis and may not be easily identified by all of the families. So it's important that we assess every time the oral cavity whenever we see the patient. Ruling out hypercalcemia is very important, intestinal obstruction, renal failure, and most important part that we've recently seen is wound odor. Patients with breast cancer with entire chest wall ulcerative fungating mass, head and neck cancers, oropharyngeal cancers with a growth internally, these patients will have a constant access to this obnoxious smell because of the necrotic tissue and the anaerobic bacteria action together. Simple way of managing the wound in a better way, using odor masking oils, like we tend to say you can use eucalyptus oil, use charcoal powder on the wound, so that will help preventing such obnoxious smell, making sure that the wound is cleaned daily. If it's an oropharyngeal cancer, pharynx involved, making them use gargles daily with salt and soda or metrogel if required, can go a longer way in trying to prevent. So always look at anything that is correctable here, which is triggering nausea vomiting. So I'm happy to, if somebody wants to volunteer based on these clinical presentations, if somebody wants to even put up on the chat, it's okay. So one of the first presentations that I had was intermittent nausea associated with early satiety and postprandial fullness or bloating. What comes to your mind first initially? Even somebody could unmute and even speak if they're okay.
You can unmute, speak, or you can just type it in the chat so that we can share.
Gastroesophageal outlet obstruction.
Yeah, it more looks like, when there's a postprandial fullness or bloating, more likely could be due to the gastric involvement. Esophageal, the patient might throw up food as soon as the patient eats. So here we can suggest something that it is more about gastric emptying issues are there. So now we have to go back and look whether what are the causes of this delayed gastric emptying, whether it's drugs, whether it is any GI malignancy causing it's a stomach cancer leading to gastric outlet obstruction. What are those concerns? So you might want to go back and look at that. Next year, sorry, I gave the answer away. Persistent nausea aggravated by sight and smell of food. So it is unrelieved by vomiting. So this suggests mainly a chemical causes, which is activating the chemoreceptor trigger zone. Now this could be due to constant, conditioned responses over a period of time, or this could be just a person because of a lot of neurochemical involvement. Next would be intermittent nausea associated with abdominal cramps and altered bowel habit. The nausea is relieved by vomiting, but that may become large in volume, bilious, and feculent. What does this usually suggest?
Intestinal obstruction.
Yeah. Thank you. I don't know who spoke about it, but yes, thank you so much. Then if you have early morning nausea and vomiting associated with headache, what would this likely be presented with?
Raised IPP or
Yes. Thank you, Mr. Deepak. So it suggests raised intracranial pressure. Nausea aggravated by movement, including motion sickness, or even just turning the head. This indicates more likely a
vestibular apparatus
yes.
disease.
Yes. So nausea and vomiting associated with anxiety, suggesting vagal,
Very good.
more likely a cortical involvement, cortical component here. So we need to just find out whether there's any fear, individual concerns, patients' certain hopes or something which is not matching the reality, any signs of clinical depression setting in, those we might have to evaluate, or if there is anything else leading to this. Thank you for interacting for these clinical presentations. So based on nausea vomiting, our take home points would be that it's common symptom for patients living with terminal illness. So there are many different causes, including the illness per se itself, due to treatments that we give, a lot of various drugs that we are prescribing, or triggered by anxiety. So it both non-pharmacological and pharmacological and certain practical tips can go a long way in helping patients with it. And if not treated on time, it could lead to serious complications. We know about it. Persistent nausea, vomiting could trigger dehydration, which leads to other organ impairment, leading to a fatal event. So, if not handled in time, patients' overall nutrition gets compromised, quality of life is impacted, their interactions are limited, they're not able to do their activities because they're not able to eat anything. So it can lead to multifold other issues. We end the topic of nausea and we move towards constipation, the last topic of the day. So we know it's a passage of small hard feces infrequently or with difficulty, and it can come with a lot of unpleasant symptoms. 2 3 days gone by, patients are not passed stools. They are quite anxious that they are not able to maintain their regular bowel regimen. Some of them might experience excruciating abdominal rectal pain, could trigger nausea and vomiting. And at times, in certain patients, in especially in terminally ill, in elderly population, patient could land up in delirium or agitation in the clinic, and you might have found out every possible metabolic or other causes of that, and it might even turn out to be severe impacted stools. So it's one of the things that we really need to assess in elderly as well as terminally ill patients. So Boland in 2020 said that in patients receiving palliative care, it can affect about more than 50% with advanced illness and about up to 87% of those who are terminally ill and receiving opioids. So when we assess, usually our question is just around, are you constipated? And the patient would say yes or no. Yes, I am. But we have not achieved more history about it, and we might just prescribe a laxative and that's done with it. But maybe more digging into it would rule out as to what kind of stools are they passing, how frequent is it painful when they pass stools, is it a satisfactory feeling of evacuation or incomplete, is there an urge to defecate, or do they notice blood in stools? Along with that, other associated symptoms are also important to look at. Patients with fecal impaction might have spurious diarrhea. So they might talk about, I'm having loose stools, or small quantity loose stools I'm passing. Our thought eventually goes towards, okay, there must be some kind of GI infection, some food toxicity, or some kind of laxative overuse. Then we might go and prescribe some loperamide, but or some other anti-secretory agents. Turns out this patient has worsened constipation the next day, because what was there was that it was hard fecal impaction leading to spurious diarrhea. There could be other issues like tenesmus, bloating, colicky abdominal pain, also accompanied with nausea and vomiting. So it's a thorough clinical assessment which will help in diagnosing or excluding even other types of opioid-induced constipation or types of constipation in this. So there are scales which help. Also, there are certain charts which can show to the patient and they can identify it earlier. So we are aware of this Bristol stool chart. Most of us have had used in our practice. definitely all of the gastroenterologists are using this chart. Daily they will refer to this chart, and it's a very simple way to just show the picture and patient will identify what kind of stools they have and you get an idea what it is. So the I talked about in the earlier slide about the Rome floor criteria. It's one of the most objective ways of assessing whether the patient has constipation or if there's any other issues. So the rule of thumb here is 25%. So fewer than 3 spontaneous bowel movements. So in a week, more than 25% times the patient has, more than 3 days, straining for more than 25%, lumpy hard stools, sensation of anorectal obstruction, incomplete defecation, or has to manually maneuver to, pass or defecate. Along with that, the frequency, consistency, everything gives you a better history. Plus, with the use of current or previous laxatives taken as and when needed, and how effective were they in resolving the symptom for that patient. So, when we are looking at possible causes, when we look at anything that could be reversed. So, most and foremost, again, I talk about medications. There are so many medications the patients are on, along with not only opioids, like even your plain antacids like sucralfate, mucane gel. The magnesium content will cause, excuse me, will cause constipation. Patients on diuretics will have dehydration, and that could lead to constipation. Iron is known to 5-HT3 antagonists, where I mentioned about ondansetron. We have a tendency to always prescribe ondansetron not as an SOS. Patient is given for 2-3 days as a TID basis, and it's an over-the-counter medication. Slight nausea, vomiting, patient will go and start and take it by themselves, and will lead to further issues like constipation. Secondary effects of illness, looking at dehydration, immobility, poor diet, and anorexia. Whether there's any intraluminal or extraluminal tumor or a mass compressing the bowel. Damage to the lumbosacral spinal cord, mainly the chorda equina or the pelvic nerves. This could lead to a lot of issues. Maybe in paraplegics is where bowel regimen is to be very much managed better in a better way. Hypercalcemia can cause, or in other concurrent diseases like hypothyroidism, diabetes, anal fissures, hemorrhoids, patients with hypokalemia, persistent hypokalemia, Parkinson's disease. So when we're looking at this symptom, it may seem like, constipation is such a simple symptom. Why should I, go about it? But when you look at it and you like really go and read a lot about it, there are so many things that come up which we may be doing it routinely. Sometimes they may get overlooked also. So I'm sure all of you who are coming in from different backgrounds here would be practicing in your regular clinical practice about all of these concurrent issues, and we are able to identify and clarify before starting treatment. So when we assess, and mainly when you're doing a physical assessment, it helps to have an inspection to see for any abnormal masses, bladder distension visible, hernias, uh, uh, there could be impacted feces. So abdominal palpation will lead you to find out whether there's any palpable fecal masses, distension of the urinary bladder. Bowel obstruction is quite easily identified clinically by ways of the type of sounds. So high-pitched tinkling bowel sounds, which we call as borygmy, is common in patients with sometimes in partial obstruction where the bowel is really in spasm and is trying to move contents ahead, or a completely silent abdomen, which is classical towards for you to identify, because patient might come up with, depending upon where the level of obstruction is, whether it's a small bowel obstruction or a large bowel obstruction, may have different signs and symptoms. So bowel obstruction might come in with preceding complete obstipation where the patient is not even passing flatus. Rectal examination might give you a more better idea, because if there is any fecal impaction due to maybe like 10 days patient has not passed stools, likelihood and patient is dehydrated, there will be further fecal impaction. Such times rectal examination might help in a better way to be able to assess. And also when you're looking in spinal cord compression, check for whether there's any saddle area anesthesia and the rectal tone, because depending upon the level of cord compression, the rectal tone would be either intact or lost. Mainly in the chorda equina and all, you'll find the rectal tone being lost, patients will tend to have more of incontinence like symptom, whereas in somebody who has a rectal tone intact, there will be more of constipation or obstipation like symptoms. So non-pharmacological ways, I'm sure everybody is aware of the positioning on the toilet and it's routinely being practiced. But other ways that you get, one is correcting the correctables. Always in palliative care, the main goal of symptom is first correct the correctables and then try to palliate any refractory symptom. Non-pharmacological methods, increasing fluid intake, oral fluid intake, not by IV hydrations and all, diet and physical activity. I know as the patient's disease advances, their performance status is further worsening. They may be bedbound. Physical activity is a challenge. But even bedside movement or passive movement that the family could help in can also improve some amount of activity in bed. Addressing other concerns that, sometimes we see patients not living in a separate room, they're in a cramped up environment, or they're in an open general ward, patient is unable to walk, they will have issues concerning privacy or access or comfort during defecation, position while they are passing stools, that all can also affect. And patient may not say it out that, because I have people around me, that's why I'm not passing stools. They might just give you a complaint that I've not passed stools since 4 5 days. But you might prescribe a laxative and go, and then next day again realize patient has still not passed stool. Why? Maybe reason is patient is bedbound, has issues with regards to privacy, is not comfortable while patients are around them and they pass stools there in that area. So it's important to even we address that aspect and rule out that cause before we just go on treating. So this chart I have shared is by the NCG, the National Cancer Grid, who had developed palliative care guidelines for each individual symptoms. It's a very busy chart. It's available on the TMC website, the Tata Memorial Center main website, where you can access these guidelines that were created, peer-reviewed and evidence-based. So this gives you a rough idea that if there's constipation, how would you approach each different case and how would you go about managing each different case. So when I talk about drugs that we use commonly, so mainly we prescribe in patients who are with uh, like a paralytic ileus or somewhere, they will give them more of stimulant laxatives, like where you'll have opioid-induced constipation, gastroparesis. You would want to consider these. So bezacodil started initially at a dose of 10 milligram in the night. Overall, you can increase the dosage. Suppositories. Senna is available in certain areas in India. You could still consider. Glycerol suppositories help in a very better way because it helps in softening of the stools as well as it acts as a stimulant laxative in the rectum. You might have heard or may not have heard about sodium picosulfate. It's available either in a tablet form or it is available in combination with liquid paraffin, where it is sold in the brand name of Cremafin Plus. We usually tend to prescribe this combination to every patient who is on opioids so that you prevent any issues of constipation in such a patient. Now, we've heard of PEGLAC. Now, a lot of patients who need bowel preparation before a colonoscopy are asked to drink PEGLAC. Now, such a solution is also available for patients who have severe constipation issues not getting resolved with other stimulant laxatives, where this can be used and it can provide a good relief of constipation in these patients, provided we have to rule out if there's any mechanical obstruction or bowel obstruction, and it should not be prescribed in those cases. The polyethylene glycerol sachet is available both in adult formulation as well as in pediatric. So you could consider using it in certain cases because the taste of Cremafin Plus or Dufalac, they're not very, the taste is very horrible and that could also trigger nausea in certain patients. Then we have the softening laxatives. We use lactulose enemas or lactulose syrup, docusate sodium, Cremafin, or organic osmotic or bulk forming, which is isabgula or macrogols. Now, again, isabgula that is available as the husk material that is available should not be prescribed on patients who are on opioids or patients who are bedbound with very minimal activity, where you know that this high fiber content could lead to fecal impaction. Along with our management, looking at other possible causes, importance to educating the family members, communicating with them about their concerns, advising them on the non-pharmacological methods goes a long way in trying to reduce the symptom burden. If and where you feel that there is a need for other disciplinary team involvement, it is better you can refer to a nutritionist who can guide them how they should be eating, what they should be, content, the quantity of food, and interval of food intake. There may be need for a physiotherapy, occupational therapy in allowing that in particular issues, positioning of the patient, if there is minimal bedside activity required, how would you do that? And any particular ways of reducing energy, reducing the energy expensed. So energy conservation techniques, how with minimal activity, minimal bursts of activity, they can continue to be less fatigued and avoid being in the bed more time, avoid being inactive, and continue to remain active as much as they are possible. So there are these various range of techniques that you can utilize. And at point, you might need to go on to supportive equipments like commonly they says people using a Western commode can use a footstool to bend their knees and be able to sit, or having a better access to a commode. Bedbound patients, difficult to pass stools, whether they could have a bedside wheelchair with a commode in it, or they can have a small bedside pot that they can be made to sit on it so that they can be taken to the washroom, or they can do it bedside, giving them railings enough to support for them to help themselves to get up from their place and move around, or walker for that, because if their activity is reduced, walker might help in reducing being in bed for longer periods. However, here sometimes patients would be very shy of using a walker. They might tend to go for a stick. It's more of a danger using a walking stick because they don't have balance. There would be other issues like some pathological fractures might develop, elderly could have fractures, any other injury could develop. So we tend to tell them to use more of walker support than using a walking stick. The other procedures that I mentioned about in this earlier, there are various ways we can help in managing um, patients who are having fecal impaction, or there where you want to consider giving enemas. Now we come across a lot of cases in pediatric population where they are neutropenic, and especially all the leukemia patients, they are on the protocol which contains vincristine, vinblastine. Now, vincristine, vinblastine is known to cause side effects like severe constipation because it affects the myenteric nerve plexus. They will also tend to develop they may tend to develop constipation, passing hard stools. Such a time we need to keep a regimen on that. The guidelines, the ASCO as well as NCCN suggest using Dofalac syrup for them round the clock every day, so that they are passing softer stools and they're not constipated. Hence, rectal procedures are always avoided in neutropenia and thrombocytopenia because one, there is risk of external infection being causing that, or bleeding locally. Other procedures here that you see placed on the side is regular enemas, high up enemas, or manual evacuations that are done. Now, high up enemas requires a bit of skill set as well as explanation to the nurse who is going to be doing it, because you need to use a lubricated catheter, usually not a very large bore, 16 gauge catheter. There were earlier in times in India, we used to have a simple rubber catheter, but that's no longer available right now. So any single 16 gauge catheters that we have that can be used to be placed high up into the rectum, and two sodium phosphate enemas can be given. This can also help in because in certain patients who have, maybe probably you would have done an X-ray abdomen erect, and you see on the erect abdomen that there is some fecal impaction. Giving a high up enema like this would prevent, it would go up and beyond the stool area, and it'll be like I'm sorry I didn't have the diagram, but if there's a stool content, you would want to go high up above the stool impacted, so that the enema is there accumulated, and from there it acts on the stool as well as on the bowel to push down the stools further for evacuation. So that is the technique that we involve in various enemas that we prescribe. So the general advice usually would be around encouraging good oral fluid intake, review their dietary charts, what are they eating and how often and what is the content. Privacy, most important, and access to toilet facilities, daily exercising if according to their ability, addressing any of the reversible factors, titrate the laxative doses. We need to educate the families also around that they may tend to develop loose stools because of laxatives. So, informing them that if they have loose stools, stop it for a day, review again the next day, and if loose stools have stopped, they can reinitiate or start as and when patients develop symptoms of constipation. Because they might tend to just rush suddenly, or they may not come to you due to the loose stools. They might go to some third person, may not be aware of, the local practitioner may not be aware that the patient is on such laxatives, would tend to put this patient on antibiotics, loperamide, like anti-motility agents, and that would lead to other issues and concerns. So educating them while prescribing them can help them address that, or they can come back to you if there is issues. If the current regimen is satisfactory and well tolerated, review this regularly and explain them about, or educating them about importance of preventing the symptom, and using more of oral laxatives if and when always possible than the other alternative routes of administration. I talked about earlier about paraplegia, where depending upon the level of the lesion, there is a different way of trying to manage bowel evacuation, or bowel, like setting up a bowel regimen rather. So very well you find patients with lesions above the T12 L1 area, they might tend to have more of a spastic bowel with intact anal reflexes. So more of stimulating agents or direct rectal stimulation can help in a longer way for them to evacuate their bowel. Initially, it may be difficult, patient might not pass with these measures, but explaining to the family that they can continue doing so and develop kind of a bowels habit, innate habit to be able to pass stool at a particular time. So they can continue training that bowel like that by giving an enema, giving a suppository or direct rectal stimulation, but every day, particular time of the same time of the day, every day. That way they help develop a bowel regimen. Whereas in certain cases where you'll have lesions less than below T12 and L1, more like a flaccid bowel, sometimes they may just pass stools. There will be lot continuous incontinence that would be there, and that would mean soiling of clothes and beds. Here, the bowel might need more training so that it is trained enough to pass stools once a day, or by using suppositories, oral laxatives, that the patient is able to evacuate thoroughly every day or every alternate day. So the key points here is regular evacuation is required every day in paraplegics, or once or 3 days in cancer patients, higher fluid intake or a phage, laxatives as needed in these cases. So that's the end of my discussion. Thank you so much.
Thank you, Dr. Krithika, for that elaborate presentation. We can take up a few questions before we move on to case presentation. If there are any questions regarding nausea and vomiting, constipation, whatever has been discussed in the last 1 hour, either you can unmute yourself and
I,
ask. Yes,
I
Dr.
had one doubt. You, ma'am, mentioned that with a high fiber diet in patients on opioids may lead to this impaction.
Yeah,
Isabgula also you mentioned, but
yeah.
like Isabgula husk tends to absorb water and increase the bulk. That's why there is a softening of the stools and evacuation of the stools in constipated patient. So how come with absorption of water impaction will happen? Means that's just a query that came
So
to my mind regarding
very
this
right. I mean,
mechanism.
that's a good concern. What happens is while you're trying to build up bulk, opioid tends to also reduce the intestinal motility. So you may go on in extending, increasing the bulk, but it should have also motility enough. So only isabgula might tend to cause that problem. If you want to judge between giving isabgula and any other pharmaceutical, laxatives that are available, I would choose more of the pharmaceuticals, because with isabgula, the water intake needs to be adequate. A lot of the patients who are on best supportive care may not have enough oral liquid intake. They may tend to have diet which is not proper on time. Very, very less oral intake is there. Activity levels are very low, plus other medications that go along with it. So when you bring all of these together, that would have more side effects rather than any benefits. So we prefer not to give.
Thank you.
There is someone asked on the chat
Yeah.
about isopropyl alcohol.
Yes,
I'm
yes.
sorry, I have never had an experience of using this, so I may not be able to answer this question.
Even I have not used or not having any experience.
I'm hearing this for the first time about inhaled isopropyl alcohol actually. And someone has asked about comfort the patient with tenesmus.
Yeah.
Mainly around with tenesmus, madam, it would be due to constant bowel spasms in that area. So antispasmodic agents, like there are patients who are with diversion colostomy still experiencing tenesmus. And that is due to probably there would be a rectal mass, a lot of secretions in that area causing that bowel spasms. So an antispasmodic here can help in trying to reduce that symptom, or we might, how discomforting is the tenesmus. Based on that, we can manage it.
Any other question? Before, I think we can start the case presentation and then take more questions.
Yeah.
Was there any question? Did someone try to speak something? Sorry. I think we'll do the case presentation and then take up more questions. Dr. Vignesh?
Yes, ma'am. Yeah. Good evening, everyone. This is Dr. Vignesh. My case presentation is based on, as you know, GI symptoms. My patient is of age 54 years, female. She was diagnosed with grade 3 rectal carcinoma with parastomal hernia and lumbar disc prolapse. Presenting complaints are persistent and progressive lower abdominal cramping pain of scale of 8 out of 10, aggravating while lifting heavy objects and relieving while lying down. Hard stools, generalized weakness, nausea, and occasional lower backache. History of illness. Patient presented to the hospital with complaints of bleeding per rectum of 4 weeks duration, and she was diagnosed with CA rectum 3 years back. Biopsy revealed adenocarcinoma. CECT thorax shown tiny calcified granuloma in superior segment of left lower lobe. Laparoscopic abdominoperineal resection, that is AP resection, was done as a part of total mesorectal excision after completion of radiotherapy. Capacitabine was given as adjuvant therapy. Patient experienced acute onset of post-operative abdominal pain and bilious vomiting, diagnosed as subacute intestinal obstruction. She was referred to another hospital for colostomy procedure. In the year 2020, she experienced sudden severe lower backache, which was eased by lying still and is often made worse while moving her back. She was diagnosed with prolapsed lumbar disc, for which non-surgical treatment were given. She has occasional history of vomiting and abdominal burning sensation also. Examination finding, general appearance was fair. The patient was conscious, oriented, well interactive with her environment, and walked towards as we approached her. Dehydration was present, and on systemic examination that was within normal limit. Temperature, BP pulse, all were in normal limit. Mental status examination shows level of consciousness and GCS all were fine. And assessment of stoma. On inspection, there was no prolapse, retraction, or infarction. Surrounding skin was devoid of any erythema, ulceration, or fistulation. Mild peristomal skin irritation was present with papular rashes, for which she used some moisturizers and now is subsiding. On palpation, surrounding area of stoma was non-tender, obvious parastomal hernia was present after feeling the cough impulse. Treatment and significant investigation. Routine blood check as per the latest report. CBC were normal. ESR was 30. RFT, LFT within normal limit. Electrolytes were within normal limit. CECT thorax showing tiny calcified granuloma in the superior segment of the left upper lobe. CECT abdomen and pelvis shown left parastomal hernia with the herniation of sigmoid colon. During the follow-up checkups, she is currently doing the follow-up checkups at an oncologist 4 monthly with the CEA report. Current CEA was on 0.5. CT done on 29/7 shows no residual current lesions. She was advised by the surgeon to digitate and assess the stoma by her own to look for any stenosis and checking the patency. All parameters were normal except the HB. HB level was still on lower side. For psychosocial aspects shown, a daughter of the patient being an Ayurveda medical student, was very much concerned about the care of her mother and prevented the stomach area from any infection. As the daughter moved to a hostel, she and her husband, who is having some comorbidities, really suffered a lot, had a severe sleep pattern disturbance thereafter. And the point which was emphasized from her husband was that the neighbors and others who are capable of providing financial help are not doing so, as those people falsely believe that their daughter would be earning well as a medical professional. They managed their previous treatments from raising money from a charitable trust, and they hardly meet the expenditure on medications and blood checkups, even though colostomy bag has been providing from the palliative care unit. Palliative care unit of the nearby PHC was very helpful in timely assessment and providing cotton, normal saline, and other protective skin wipes. Unit staffs, as we can see in the image, makes a weekly routine checkup to ensure about the patient's health condition. Moving to the medications, post-operatively, she was given capacitabine 500 mg, Diclo 50 was given as an analgesic. For constipation, currently she is using Cramafin Plus. The patient was started on morphine tablets with a dosage schedule of 10 mg at 8 p.m., 10 mg at 12 noon, 10 mg at 4 p.m., and 20 mg at 8 p.m. For stomach care, Coloplast, skin barrier cream, Caraya powder, and ostomy powder were used. Main concern was pain, which was low backache and abdominal cramps, nausea and constipation, which is not relieving on Cramafin Plus, which is probably due to the stress and dehydration. Though she is covered under Karunya insurance scheme, but still have some financial problems as her husband is also having some comorbidities. Stomach care is also a concern. Summary, 54-year-old female with all rectal carcinoma on colostomy bag and a known case of parastomal hernia. Main discussion points. What are the pain management options for this patient? What all things are advisable to relieve the nausea and constipation? How to reduce the mental stress? And what all can be done for her family? How to maintain adequate stomach care?
Thank you, Dr. Vignesh.
Thank you so much, ma'am.
So I'll ask the other participants, what do you think? Do you want to ask more questions or you need more clarity? Or what do you think about managing this patient? For today's discussion, we'll start with the management of nausea and constipation, and then if time permits, we can take up the other questions also. But what do you think about managing nausea and constipation in this particular patient? I'll wait for the chat or someone to unmute and speak.
Though in the discussion in this presentation, I saw that the morphine intermittent release tablets were being given, but the schedule mentioned, I think one more dosage needs to be added. Like the dosing was being started from 8 a.m. in the morning, and the second was given at 12, and then again at perhaps 8, and then one last dose for the night, the double the dose. So I think if it started from 6, then one more dose can be added to the schedule.
Thank you, Dr. Deepak. I think the morphine was prescribed 6th hourly. Dr. Vignesh, do you see this patient directly, or
Yes,
was there
ma'am.
any reason for the 6th hourly dose? Was she having any toxicity or any other issues?
No other issues, ma'am. She is currently taking this 4 times. Morphine.
Thank you. And there is another comment from Dr. Subbulakshmi that ondansetron can be given. Any other comments from your side before asking Dr. Krithika? Another suggestion on metoclopramide. Anything else? Dexamethasone, yeah, Dr. Shivkumar. So laxatives to relieve constipation. I think it's already she is already on Cramafin Plus, but still has some difficulty in passing stools. domperidone, dexamethasone. Yeah, there are many options coming up. So yeah, as Dr. Krithika was mentioning, asking, what are the likely causes of nausea before we end up in prescribing all these medications or discussing that? I think we should start thinking from what she was mentioning during the session. Also, it's very important to understand the pathway involved and the reasons for nausea. And what do you think about this particular scenario? Adding of a stimulant laxative. I think over to you, Krithika. What do you think about this? I think you will have more questions to ask about the nausea so that we can understand where it is coming from.
Yeah. I mean, what are the possible physical issues? I mean, it's if you put it in the 4-box model of assessing any pain, there are physical issues here. I can see that there are psychological issues here. And there could also be some kind of a luminal obstruction that we could be thinking here. Because the parastomal hernia is that hernia leading to stomal obstruction so that appropriate stool output is being prevented, whether that is the reason, whether that's a reversible prolapse or irreversible prolapse. So that all will help you identify how would you proceed with this management.
As the patient have dehydration, more water intake and food management will be helpful, as Dr. Ashwati is
Yes,
suggesting.
very important point here.
So, do you think Dr. Vignesh is she's not drinking and eating properly because of the
Yeah,
nausea?
she is very anxious, ma'am. She is very anxious about her husband's condition also. He also have some comorbidities also. I mean, some cardiac diseases. So she is concerned about him also.
Not because that she's nausea, she's having nausea that she's not able to drink and eat. It's mostly because of the anxiety that she's
yeah.
not drinking. Any other comments?
Then the nausea will be mainly due to the cortical reasons.
Could be, yes. Anxiety triggering it. So there will be it will be multi-causal. It won't be a single cause affecting here. You would want to also investigate to rule out any abdominal pathology, to whether maybe like a simple X-ray abdomen erect to rule out if there is a recurrent obstruction now, like a partial obstruction setting in, that she may be passing some stool output in between nausea. So there could be a partial impending obstruction. So a simple X-ray abdomen might help. Whether due to the peristomal hernia, is there any impacted feces in nearby the stoma that she's not able to maneuver to empty it? That will also be identified with, you can see impacted feces on the X-ray. So before we move on to adding a drug here, is to always investigate it out. So even auscultation to find out bowel sounds, how they are, where that could help you to clinically diagnose whether it's constipation. I mean, that's whether there's any obstruction or not.
So there is another suggestion on dose modification of either capecitabine or morphine, if that's the reason for symptoms.
Yes.
So I think, Dr. Vignesh, you have done a very thorough pain assessment using the scales and this thing. But I think it's also important to, as it was mentioned in the presentation, to go much in detail about the assessment of nausea and vomiting. When it is coming, is it associated with food? As you were mentioning, she's very anxious. Is it that
Yes,
when
ma'am.
she's thinking about all these family things, she feels nauseous? Because that then the management completely changes from giving ondansetron or metoclopramide to dealing it more with an anti-anxiety drug. So it's very important to take the history of nausea like that you have done very well in pain. So the same way we can assess nausea and vomiting. I think any symptom, should be assessed in that way, so that you know where it is coming from, what can be the probable causes. So according to the causes, now we understand that the management plan also changes. It's not just a single drug for all the nausea and vomiting. So depending on the causes, we need to think the reasons, and then correcting the correctable, and then decide upon medications. And as someone was mentioning, Dr. Deepak was mentioning regarding the dosage of morphine. So if there is no other toxicity involved in giving immediate release morphine, you can easily give the normal 4th-hourly dose of morphine. Like sometimes people prescribe 6th-hourly because the patients might have a toxicity history, some myoclonus or extreme drowsiness with 4th-hourly dose. So if there are no such history, then it's very much advisable to change it back to the 4th-hourly dose and then assess pain. And when you assess pain after giving morphine, when you say unrelieved pain, it is really important to understand after taking morphine how much the pain score comes down and for how long it stays. Then you understand whether it is opioid sensitive. Do you actually need to add on something or to increase the dose? So it's very good to understand those small details, how long the pain relief lasts. Suppose she takes morphine now 6th-hourly, she takes at 8 a.m. and she has good pain relief for 4 hours. Then the pain starts. In that case, the 4th-hourly dose will work much better than the 6th-hourly. So it's very important to give attention to those details when we address unrelieved pain, especially when she doesn't have any toxicity. And I think the mental stress, I understand that her husband is also having comorbidities. So maybe I don't know about the other states, maybe in Kerala, we have the NCD clinics which provide free medications. So the problem is that the patients might be consulting a private doctor and getting all the medications, which may not be received from an NCD clinic. So it's very important that if they can approach, all the PHCs will have an NCD clinic, I guess. I'm not sure about the other states. Someone can actually enlighten me on that. But in Kerala, the non-communicable disease clinics are there with every PHC. So they give the diabetes, hypertension, cardiovascular problems, many of these medications for free. So it's important to get them in touch with already available services. So it's much more easier for them to get access to these medications. Anything else, other participants, what do you think about the mental stress on the patient and family? Because they're anxious, others are not helping financially. And I understand the stoma care or the colostomy bag costs a lot. And that's one of the biggest worry that patients come to us also. Like, we don't have money to buy these bags. And her husband's medication. So any other inputs from other participants to manage this situation? Anyone?
I just wanted to tell about that stoma thing. I had
Yes.
seen a lot of patients in TMH also who were not affording stoma bags. So I can't recollect the company name, but you get a kind of a plastic ring with a central hole, like it's like a donut shaped ring, and it's got a clip where you attach any bag to it. So a simple household bag that they would have at home. Only thing that they need to do is that bag needs to be changed every day or every 2-3 times if the output is very high. So that bag, and it comes with a band which goes around the at the waist level. So they place that ring on the stoma with a clip, with the plastic bag clipped onto it, and that then the belt is tied around the abdomen, and that secures that ring over the stoma. This may allow probably to avoid in very severe cases where financial is really an importance and they are not able to afford even the stoma bag. This could come as an option. I don't know now where you might find it. It's a little difficult, might have to search around a bit and then assess. But we had seen that it was helpful. Only problem with that is the excoriating of the skin, because you're not sticking it intact. So there could be a lot of fecal matter causing. But using like Coloplast and all of these ointments, which can at least help prevent skin excoriation, can help. Another thing I would like to point out for that mental stress is, why not refer her to a counselor or a clinical psychologist who can at least address her concerns, her distress. That way they will be able to at least identify what are the other issues she has. As Dr. Sri Devi also pointed out about free clinics where the patient can get, or a social worker where they can be diverted for this reason. So involving you only doing everything by yourself will be very difficult. So when you take help from associated people, they can guide around, help them with maybe accessing a trust who can help them with some monetary benefit right now issues, or clinical psychologists can help identify any mental conditions that she might be going through, any pathological issue for which you can give treatment. That way you can manage that mental stress also, reduce the distress due to other factors, and then come back to whether it's improved her symptom or it has not.
Thank you, Krithika. Vignesh, can you tell me a bit about the constipation? I totally she's passing stools every day, but with difficulty. Is that what
Yes,
you-
difficult. Yeah.
Okay.
She
Difficulties.
laxative. I mean, Gramafin Plus is used to use.
Okay.
She's using Gramafin Plus, but still having problems with the constipation.
The stools are really hard. What is
Yeah.
she? Yeah. Okay. But opens every day, right?
Yeah. Yes.
And she examined the stoma with her finger as the
Fingers
surgeon suggests.
manually. She is doing by her own.
Okay. And do you think increase in the dose of stimulant laxative would help? Like what dose of clemapin she is in? Is that
She
helping or not?
30 ml HS.
Okay. Krithika, would you like to comment on that, the constipation part of it?
You could add another stimulant like Bisacodil oral tablets to this regimen along ongoing Cramafin Plus, and see for a week. If it doesn't resolve, you could even consider polyethylene glycol. If you have ruled out obstruction and all other causes, or peristomal herniation causing any bowel obstruction, then you could consider with this regimen and see if it helps her. So Movicol sachets, maybe initially twice a day. If doesn't resolve, thrice a day. Or you can even consider first is mainly because I know cost is there. So I'm being mindful of that because my Movicol will be quite expensive for her. But you could give her a good dose of, you can increase the dose of Clemafin Plus. You can make it twice a day. Along with that, you can add a Bisacodil regimen to it. So making 2 tablets in the night, making it up again to 2 tablets in the daytime. That way, if she will be able to, evacuate her bowels.
Thank you. And I totally agree to involve a counselor or a social worker just to understand whether how about more about her anxiety and stress that itself can cause all these symptoms and can worsen the existing symptoms. So it's very important to have a discussion separately with the patient as well as with the husband, and to understand how we can move forward with that. So that's very important to do. Any other comments from the participants? Otherwise, we can wind up. I hope Dr. Vignesh, your questions were answered. If you
Yes,
have
ma'am.
any queries, just write to us through email or the WhatsApp group that we have.
Sure, ma'am.
We'll be able to address if you have more concerns. Any other comments or questions before we wind up? Okay. Thank you so much, Dr. Krithika, for that session. You were very sick. That was quite understandable. Thank you for making this happen. And please take rest
Thank you.
after this year. And thank you everyone for joining us for today's session and for the interaction as always. Sri Priya.
Thank you, Dr. Sridevi, and thank you, Dr. Krithika. We do understand how little bit weak you are, but still you managed such an elaborate discussion, I could say, because it was an expensive, complete 1 hour, and I was just feeling myself that may she get well soon. So thank you everyone for joining us for that wonderful discussion. I believe everyone had a better understanding about today's topic after this discussion. Next session we'll be having a continuation of this with another faculty. So till that time, this is Sripriya along with Dr. Sridevi and Dr. Krithika signing off from the Tips Echo desk. See you everyone. Take care. Bye bye, and don't forget to leave your feedback.